My name is Luis Mora and I'm going to present a research topic. I'm going to talk about C-type natriuretic peptide analog therapy in children with achondroplasia. First, we have a definition. Achondroplasia is a genetic disorder that inhibits endochondral ossification, resulting in disproportionate short stature and clinically significant medical complications. Bosuretide is a biologic analog of C-type natriuretic peptide, a potent stimulator of endochondral ossification.
Achondroplasia. What is achondroplasia? A means without, chondro refers to cartilage, and plasia means growth. So this is basically impaired cartilage growth or proliferation. This is a common cause of dwarfism, and as you may notice from this picture, these individuals have a normal head and a normal trunk. And the reason that this occurs is, if you may recall from embryology, there are two types of bone formation. Intramembranous bone formation, this is not affected. However, you may notice in these individuals that their extremities are shorter. They're not developed properly. This is due to impaired endochondral cartilage bone formation. These individuals have an activating mutation on the fibroblast growth factor receptor 3. So the FGFR3 is increased in expression, so you have too much of this receptor on the cell surface, and what your body does is it responds by saying, hey, you're giving too much of a growth signal, so they're going to inhibit growth. So growth is going to be inhibited. Achondroplasia tends to be sporadic. It has an autosomal dominant inheritance pattern. Fertility, lifespan, and mental function are not affected in these individuals. So they have normal fertility, lifespan, and mental function. The incidence of achondroplasia increases with increased paternal age. So looking at this x-ray, we notice that the long bones have not developed properly. And the reason that these long bones don't develop properly is because the main mechanisms that long bones grow is due to endochondral bone formation. In summary, achondroplasia refers to impaired cartilage proliferation that inhibits growth plate and long bone formation, and these individuals end up with short extremities. However, their head and trunk are normal. And the mutation is an overexpression of FGFR receptor 3. It is an overexpression of FGFR3 that leads to inhibition of growth.
Next, we have the application in medicine. No pharmacologic therapies have been approved for achondroplasia, except for growth hormone, which is available for this indication in Japan. Increases in height in children with achondroplasia who are treated with growth hormone occur mainly during the first 2 years of therapy.
The diagnosis of achondroplasia is fairly straightforward in that in the first month of life is generally apparent to the pediatrician, the alteration in proportions of the body of the infant, which leads them to the suspicion, and then through genetic testing is possible to confirm the diagnosis. There are other conditions that resemble achondroplasia that need to be ruled out. For example, hypochondroplasia or pseudochondroplasia, which are also genetic conditions, but they are resulting from different types of genetic mutations.
Now we have the pros and cons. The effects of growth hormone on disproportionality are unknown. Limb lengthening surgery improves height, but does not prevent associated medical complications. In addition, the surgery is controversial because of its invasiveness and a high rate of complications. C-type natriuretic peptide encoded by NPPC and its receptor, natriuretic peptide receptor 2, are potent stimulators of endochondral ossification.
A peptide of 22 amino acids, derived mainly from cells of vascular endothelium. It is also found in the brain, major endocrine glands, and other tissues. It shares structural homology with atrial natriuretic factor. It has vasorelaxant activity, thus is important in the regulation of vascular tone and blood flow. Several high molecular weight forms containing the 22 amino acids have been identified.
Now we have the Asian equator. Bosaritide is a recombinant C-type natriuretic peptide analog that was developed to have a longer half-life than its endogenous form in order to prolong pharmacologic activity. Once daily subcutaneous administration of bosaritide promotes long bone growth in juvenile, skeletically normal mice and monkeys and corrects the dwarfism phenotype in mice with achondroplasia.
Is there any medicine or cure for achondroplasia? What are the chances of having another baby with other form of gene mutation if you have one achondroplasia boy? So the first question, again, relates to, I assume, the BMN 111, which I think has been answered. There is no cure for really any genetic condition, but there are many different ways which we can manage and treat those patients. And certainly there are well-established treatment protocols, screening protocols, management protocols for kids with achondroplasia. And again, I would hope that there are specialists who are helping to take care of this child. The second question relating to, I guess this is risks for recurrence risks. So if we have two parents of average stature and they have a child who has achondroplasia, the recurrence risk for that particular couple would be approximately 2 or 3%. The reason being, typically we think of achondroplasia and other new dominant conditions for a family as being caused by a spelling mistake in either the sperm or the egg, which occurs at the time of conception. If that were in fact the case, the recurrence risk should be the risk in the population, which we would estimate to be about 1 in 25,000 births. However, it is possible that the spelling mistake did not occur at the creation of the sperm or the egg, but rather in tissues that created the sperm or in tissue.
Now we have the conclusion. In children with achondroplasia, once daily subcutaneous administration of bosaritide was associated with a side effect profile that appeared generally mild. Treatment resulted in a sustained increase in the annualized growth velocity up to 42 months.
I'm Erin White with today's Health News. There's a possible new treatment for dwarfism on the horizon. BioMarin Pharmaceutical Incorporated announced last week that a drug called vosoritide improved the growth of children with dwarfism. Children grew an average of 50% more with a daily dose of the injectable drug. If approved, it will become the first drug approved to treat dwarfism in children. The company plans to conduct a larger trial to confirm the findings and in hopes of approval from the U.S. Food and Drug Administration.